for Testing and Training, which was published in 2013. And then anyone who's interested, Tom Sarma and I published a book chapter with this same title, Exercise Physiology for the Clinician, in the Compendium of Sports Cardiology by Paul Thompson a few years ago. So if you'd like a copy of that, please just email me. I run a program called the Institute for Exercise and Environmental Medicine. It's about 10 miles to the northeast, just on the other side of Presbyterian Hospital. It's a unique partnership between Texas Health Presbyterian Hospital of Dallas and UT Southwestern. And our mission is to promote basic and clinical research, education, and clinical practice in defining the limits to human functional capacity in health and disease, with the objective of improving the quality of life for humans of all ages. We are set up around something called the oxygen cascade, and I'll go through that in a little bit more detail in a minute. But the bottom line is we have established laboratories at every step along this pathway to help us understand the limits to human functional capacity. We've got, depending on how you count them, 13 faculty members. The group on the top are the ones who work with me in the cardiovascular laboratory. I just want to give a quick shout out to Renee Guillot, who is part of your department in the Physical Medicine and Rehabilitation Department, who runs our hyperbaric medicine and diving medicine programs. We have lots of postdoctoral fellows, both MDs and PhDs, generally anywhere between 15 and 20 of them. Tiffany Brazil and Dennis Wakeham are currently the two in the cardiovascular lab who are working with me, and we'd love to talk to any of your trainees who are interested in doing advanced research in exercise or human physiology. Now, I told you I would talk about the oxygen cascade, and this is the path that oxygen must follow from the environment down to the mitochondria to make ATP aerobically for physical work. And obviously, the higher up you go on the Earth's surface, represented by this mountain, the less the partial pressure of oxygen. The lungs are the primary interface between the body and the environment. Oxygen comes into the lungs, then makes one big diffusion step into the pulmonary capillaries, is pumped around by the heart to the skeletal muscle, where it makes a second diffusion step into the mitochondria, where it's used to make ATP. And that whole process is controlled by the brain, which distributes the blood flow where it needs to go. Now, this is this process, the oxygen cascade, was really highlighted, I think, very nicely by a very famous paper by Hans Hoppler and Ernst Weibel, where this is just basically a pictograph of the same process of the lungs, the circulation, and the mitochondria. But I show it because it shows it gives you context for the magnitude of where blood goes and where oxygen is utilized in the human body. So the dashed lines, the dashed part of this bar represents the skeletal muscle at rest here in this lower bar, with a little bit in black to the heart and a little bit more in dotted line and dots to everywhere else. When a sedentary person exercises, the vast majority of that increase in oxygen uptake and blood flow goes to the skeletal muscle. Really almost more than 10 times an increase, and in a competitive athlete, it may be 20 times. And virtually all of that increase goes to skeletal muscle. Now, the maximal rate at which oxygen must flux to get from the environment down to that mitochondria is called the V.O2 max, or the maximal rate of ventilatory oxygen uptake. And that is an important determinant of athletic performance. This is just one example of a slide from Doug Seals' lab. It turns out to be entirely in female athletes, but females, if you look at the VO2 max on the x-axis and 10,000 meter running speed, you can see a very tight relationship. The greater your VO2 max, the faster you can run. And if you want to learn a little bit more about this whole concept of VO2 max, There's a nice review that I published in the Special Olympics version of Journal of Physiology in 2008, which goes over that in some detail. But it's important for you all in the clinical world to recognize that VO2 max is not just important for performance. For example, one metabolic equivalent of task, which we call 1-MET, represents resting oxygen uptake, 3.5 milliliters of oxygen per minute per kilogram body mass. Now, it takes about twice that much to walk nice and slowly at 2 miles an hour, just on a level ground. If you want to walk a little faster, about 4 miles an hour, that's a nice brisk walk. That's about 3 METs. If you can't do 5 METs of activity, it doesn't really matter what your disease is, that represents a very poor prognosis. And that's usually what we limit patients immediately following a myocardial infarction, for example, and represents the peak cost of basic activities of daily living. If you can do 10 METs, then the prognosis of someone with a heart attack is as good with medical therapy as it is with bypass surgery. And that's about the average fitness for a well 40-year-old male. 13 METs, which is even more. It doesn't matter what your exercise responses are. It doesn't matter if you have ST depression. It doesn't matter what your blood pressure is. If your body can do that much work, you have an excellent prognosis in the next few years, regardless of underlying diseases. Good endurance-trained athletes get about 18 METs, and world-class competitive athletes are closer to that 20 MET mark. So that's 70 mLs per kg per minute. Now, if VO2 max is so important, how do we measure it? Well, it typically requires some way of increasing exercise stress with a treadmill or a bike, or we have a swimming flume in our laboratory, and you have to collect the expired gas that the athlete is breathing. And if you increase the work rate, you increase the oxygen uptake. And there comes a point, though, where you increase the work rate further and you no longer get any more oxygen extraction. And that's called the V.O2 max. Now, the slope of this line, particularly at lower levels of activity, is called the economy or the efficiency of motion. And if I extrapolate that economy to VO2 max, that's called the velocity of VO2 max. And that represents pretty much what people will run at during a 5,000 meter race. That's how fast you can go. Now, obviously, over shorter distances, you can go even faster. You can generate higher power outputs. And that's called a supramaximal work rate. So let's say that I have an individual athlete with a VO2 max of 64 mLs per minute per kilogram. If I put them on the treadmill at a work rate that would require 80 mLs per kg, and then I start them at 0 and collect all their gas over a period of time, gradually the oxygen uptake will start to build up until it reaches VO2 max. But obviously, especially at the beginning of exercise, there's a big discordance between the oxygen uptake that you can establish with your mitochondria and what work rate that would require. And that's called, that comes from anaerobic energy sources. And if you take the total duration that you can exercise, you can calculate this as the true anaerobic capacity. That's different from what you all think about it in the term anaerobic threshold, and I hope to dissuade you from using that term in a little bit. Now, for athletes, for those of you who work with athletes, you realize that this kind of work represents different bounds and requirements of different sports. And as part of the Bethesda Conference Guidelines for the Management of Athletes with Heart Disease, we established this classification of sports depending on the dynamic component, how much endurance exercise that requires, and the static component, how much strength that requires. And we call low less than 50%, moderate 50 to 75%, and high more than 75% of VO2 max. And we call low static about 10% of a maximal voluntary contraction, moderate 10 to 20, and high greater than 30%. And you can see that you can generate a range of different activities from bowling, cricket, or golf, or riflery at the low end, and particularly rowing or decathlon or competitive cycling, triathlon at the high end of both static and dynamic exercise. Well, how do we generate these individual boxes? And I do want to emphasize that these lines that establish the categories are not fixed. They're kind of light on purpose, and the colors blend into each other as you go across the categories. That's because there's no magic line in the sand where all of a sudden you go from low to moderate to high. Most sports require a combination of different kinds of physical activities or intensities throughout a season, throughout a game, throughout an individual competition. So where does this come from? Well, in part, it comes from the cardiovascular adaptation that we see in these athletes, which is a reflective of the circulatory regulation that occurs during exercise. And I stole this figure from my mentor, Jerry Mitchell, who unfortunately passed a couple of years ago. And Jerry emphasized a few different things. That is, as Kathy was mentioning to you just at the end of her talk, the cardiovascular center, which regulates the circulatory control, is in the rostral ventral lateral medulla, the nucleus tractus solitarius, actually. And it receives a lot of input. It receives a central cortical irradiation called central command, which initiates the exercise response. It receives feedback from arterial barreflexes. It receives feedback from exercise skeletal muscle and feedback from the heart itself, cardiac mechanoreceptors. All that is integrated, and efferent, these are the afferent fibers. Efferent signals are sent to cause constriction in the renal and splanchnic circulation. It causes constriction in the inactive skeletal muscle and increases the strength and the frequency of the heart's contraction. Now, those same signals go to active skeletal muscle, but active skeletal muscle doesn't constrict, it dilates because of release of metabolic vasodilators. And because the skeletal muscle is so important in regulating this cardiovascular response, I want to just talk a little bit about what happens in skeletal muscle as you try to increase exercise. So that's where we generate the ATP. And one critically important concept I want to make sure everyone understands is that which was elaborated by the famous muscle biologist George Brooks, who described this thing called the crossover concept. And what that means is that as you increase the intensity of effort, the sources at which you burn to generate that ATP change. So at rest, the vast majority of ATP is produced aerobically from fat, with relatively little by carbohydrate. If you increase that intensity, the amount that comes from fat percentage-wise starts to decrease, and the amount that comes from carbohydrate starts to increase. And this point is called the crossover point. If you exercise train someone, you can push that point out to the right. If you detrain or increase sympathetic stimulation, that pushes that point to the left. So what does that mean for athletic performance? And one way to assess that is to ask what happens when you don't have as much oxygen available. And this is a great paper published now, 30 years ago by Perrinet, which looks at how fast you can run, the percentage of your sea level speed at 100% as you go up in altitude at different durations of activity. So notice that the biggest fall off with altitude is in the marathon, which is run relatively slowly and requires virtually entirely an oxidative sources of energy. And the faster you go, the shorter the duration, the less that is influenced by altitude. And in fact, as you go to very short duration activities, things that last 10 or 20 seconds, frankly, you don't need oxygen at all. And as you get up to altitude, you can actually go faster because you reduce the wind resistance. 400 meters is probably that critical distance or speed, lasts about 45 seconds to a minute, where you go faster up until about 8,000 feet, and then you start to go slower because it's a combination of aerobic and anaerobic energy sources. So what does that mean, and how do you then generate this oxygen uptake? And if you're not paying any attention to me, and if you only remember one graph, one figure from this talk, this is the one I want you to remember. This one shows a part of the Fick equation, which represents the cardiac output, QC, shown on the y-axis, as a reflection of the oxygen uptake. And this is an extraordinary relationship. For every liter of oxygen uptake, you need 5 or 6 liters of cardiac output. And it doesn't matter if you're young or old or a man or a woman or sick or well or an athlete or sedentary, it's all the same, except sometimes. Now, one of those times is patients with congestive heart failure. They have an impaired cardiac output response, and their slope of cardiac output to oxygen uptake becomes blunted. And this is hugely important clinically. For example, here's a paper published by the Vanderbilt group, also a long time ago now, showing over a year the survival in those with a normal cardiac output response, shown up here. Virtually everybody survives. But if your cardiac output response is reduced, more than a 25% mortality at 1 year. That's a quite dramatic mortality. The other time that this relationship falls apart is those patients who have metabolic myopathies. And we learned that from Dr. Ron Haller, and they actually have an enhanced or hyperkinetic circulation because their muscles are not extracting oxygen, and there is an error signal saying we don't have enough blood to make ATP, and so the signals from skeletal muscle are driving the cardiac output response to exercise. That's where a lot of this knowledge base comes from. So I mentioned the Fick equation. Let me remind you what that is. It says oxygen uptake is a function of two things, the cardiac output times the arteriovenous oxygen difference. The AVO2 difference represents those peripheral factors involved in oxygen extraction. The cardiac output, which is heart rate times stroke volume, reflects those central factors. I want to spend a few minutes talking a little bit about the regulation of stroke volume, since it is so critical to the exercise response. If I were to be standing in front of you, I would emphasize to you that gravity is sucking blood into my feet. So the vast majority of the blood volume is below the heart when you're standing still. When you start to exercise, the muscle pump now drives all that blood centrally. And that's the main way that you increase stroke volume during exercise. And here's some data just to show you the differences between athletes in white and sedentary individuals in yellow, published by one of my postdocs a few years ago. As you increase the oxygen uptake, notice that the stroke volume increases very early, within the first 50% of your oxygen uptake. And in most people, sedentary, it remains there throughout the entire exercise capacity. There may be some increase in elite athletes. Not everybody has shown that. This happens to be masters athletes. And one of the things that limits this stroke volume is probably the pericardium. How do we know that? Well, my good friend and colleague, Jim Stray-Gunderson, who unfortunately also just passed last fall, and I show this picture because we miss him. Jim did a study in Jerry Mitchell's lab where he actually removed the pericardium from a group of greyhounds, ran them on the treadmill. And before the pericardiectomy, stroke volume goes up, but tends to plateau. After the pericardiectomy, stroke volume goes up dramatically. and as is cardiac output and oxygen uptake. Now, we've not yet had a lot of athletes come to us and ask us to take off their pericardiums, but it's a big procedure, but it just emphasizes that physiology. Now, when the stroke volume goes up, I told you that cardiac output is well regulated, and therefore the heart rate is matched to that stroke volume. Athletes have bigger stroke volumes and lower heart rates at any given absolute oxygen uptake, though the peak heart rate is generally about the same, if anything, a little lower in the athletes. Now, to help convince you at how precisely this is regulated, what I'm going to do is show you one more triptych graph, which instead of showing the absolute oxygen uptake on the x-axis and heart rate, I'm going to show you the relative heart rate as a percentage of VO2 max. And now, between the sedentary and the athletes, these are superimposable. And what that tells us is the heart rate is regulated to the stroke volume to preserve the cardiac output. Now, what happens to heart rate when you increase the work rate? This is pretty much everybody knows this. As you increase the amount of work and oxygen uptake, the heart rate increases, and then that rate starts to slow. This is called the Conconi heart rate, or the heart rate breakpoint. If you measure ventilation, shown here in white, it starts relatively low and then begins to increase as exercise increases. And if I have a little lactate device where I can measure finger lactate, I can measure lactate, and that matches the ventilatory pattern pretty well. And if I train somebody, I can push that lactate curve to the right. And that becomes really important at those higher but not maximal levels. So for example, in this individual, at our work rate of 3.5 liters a minute, lactate's going to be extremely high, maybe 8 to 10. But after training, it's now down to 4. So it makes a huge difference to shift these exponential curves to the right. Now, what's really interesting is that all of these 3 points, the Conconi heart rate, the ventilatory threshold, and the lactate threshold, are all at about the same work rate. And I like to call that the maximal steady state. Although you will hear the term anaerobic threshold, which has been solidified in the literature by Carl Wasserman and the MedGraphics metabolic cart, this is neither anaerobic and perhaps not even, certainly not an anaerobic threshold. In fact, the vast majority of energy, even at max exercise, continues to be from aerobic sources. It's not a point where all of a sudden you switch from aerobic to anaerobic metabolism. But it is a point where the rate of ATP generation from glycolysis and substrate levels phosphorylation starts to increase because the rate of ATP generation by anaerobic sources is faster than by aerobic sources. So we'll call that the maximal steady state, not the anaerobic threshold. And typically that occurs at about 65 to 75% of VO2 max, or 75 to 85% of the heart rate max. If you use a typical off-the-shelf metabolic cart, you'll see figures that look like this. So this is the VO2 on the x-axis and VCO2 on the y-axis. And if you draw a line between the upper and the lower parts, that's how their machines generate what they're calling an anaerobic threshold, which is really the ventilatory threshold. And you can also find it as the nadir of the relationship where VE-VCO2 or VE-VO2 reach a nadir. I don't like the curves that are expressed per unit time because time is an irrelevant number. What matters is work rate, and that depends on the protocol. At the end of the day, though, this point, this maximal steady state, is important for athletic performance. And we typically use the heart rate at maximal steady state, as well as the max heart rate, to develop training zones for competitive athletes. So let's just say, for example, we measured the maximal steady state from lactate or ventilatory threshold at a heart rate of 165 in an athlete with a maximal heart rate of 200. We would then bracket that by 5 beats a minute and call that threshold or maximal steady state. And that's about the pace that this athlete would run a marathon. If we drop that by 20 beats a minute, 140 to 159, that's what's called base training. That's a typical endurance base. And that's an ultramarathon or a triathlon pace. We also include a recovery zone less than base pace, because every high intensity effort should be followed by a recovery effort. Critical power is a little bit more difficult to measure, though I put it in between threshold and intervals. Critical power is that intensity above which cannot be sustained, and you drift up to VO2 max. Critical power is about a 10K pace, and intervals are 5K pace, which is run at VO2 max, or shorter distances, like I showed you, with increasing amounts of glycolytic energy sources. Now, this is relevant not just for competitive athletes, but for any of your patients. And in fact, you can go ahead to look at the compendium of physical activities and to look at a variety of different self-care, occupational, recreational, or conditioning exercises, which range in from very light to light, moderate, and heavy or very heavy intensity. This comes from this particular site, the Compendium of Physical Activities. You can look it up on the internet. You can pick an activity that you want and figure out what the VO2 max and the MET level required to be able to do that activity. Now, this is relevant not just for functional capacity, which I know you all in PM&R spend a lot of time thinking about, but also for survival. Here's some data that I'm going to show you from Framingham and the Cooper Clinic that used to be called the ACLS, the Aerobic Center Longitudinal Study, and now is called the CCLS, the Cooper Center Longitudinal Study. But here's the survival of 42,000 men based on the Framingham risk score. Low in red, 10 to 20% in orange, and high, greater than 20% in blue. So the greater the Framingham risk score, the greater the risk of cardiovascular death, myocardial infarction, or myocardial infarction death. If I look at METs on a treadmill, actually that gradient is, if anything, even steeper. So if you can do less than 10 METs, that's the lowest fit level. And I mentioned to you before, if you can do more than 12 METs, boy, death is really, really low, less than 10%, and coronary heart disease less than 5% per 10,000 person years. And this is also true in women. Here's the data for Framingham in women and METs in women. So both men and women, you have to be a little careful about what numbers you use for MET levels. That's what complicates the interpretation across sexes, but the gradient remains the same. And we have argued that fitness then should be a vital sign. This is a scientific statement that I was part of back in 2016, which emphasizes this particular figure that I just showed you, that if the higher the fitness, the lower the death rate. And we made very specific recommendations for measuring cardiorespiratory fitness during routine clinical visits. Now, you can actually do this now in EPIC. You can activate this in UT Southwestern EPIC. It's called the Physical Activity Vital Sign under the Lifestyle section. And it's pretty simple. It asks, on average, how many days per week do you engage in moderate to strenuous exercise? And you pick 0 to 7. And then how many minutes do you engage in exercise at this level? And it comes out with a number which multiplies one by the other to give you the minutes per week. And it's a great opportunity to start that conversation with patients about how much physical activity they do. And we should get aiming for 150 minutes total per week as a physical activity guidelines. Now, I want to transition from talking about external work rate, that's how much work can the person do, to internal work rate. How much stress does exercise put on the heart? And I'd like to remind you all that myocardial oxygen utilization is dependent on 3 things: wall stress, heart rate, and contractility. Wall stress, of course, is the left ventricular pressure times left ventricular volume divided by wall thickness. Preload is wall stress before the onset of contraction. Excuse me. Afterload is wall stress after the onset of contraction. And although it can be challenging to measure, in clinical practice, we use something called the rate pressure product. That's the max heart rate times the maximal systolic blood pressure. So how good is that at estimating myocardial oxygen demand? Well, heart rate is a function of cardiac output times total peripheral resistance. Blood pressure is a function of cardiac output times total peripheral resistance. Cardiac output is heart rate times stroke volume. So the rate pressure product is proportional to the square of the heart rate, which is the most expensive component of myocardial oxygen demand, times the stroke volume, influenced by preload, and TPR, which is afterload. So it actually turns out to be pretty good. And you can rewrite the Fick equation for any organ, including the heart. So myocardial oxygen uptake is a function of myocardial blood flow times the AVO2 difference. But there's one really unique aspect of the heart that is different from the general overall skeletal muscle. And that is the heart pretty much extracts all the oxygen that comes to it, even at rest. So the only way to get more oxygen delivered to the heart is to increase myocardial blood flow. So how do you do that? Well, we know that the coronary arteries will dilate during exercise. These are very famous studies from Betsy Nabel's laboratory at the Brigham, which looks at the diameter of a coronary artery as a percentage of control at rest. And during exercise, you get about a 20% dilation of the large epicardial coronary arteries. And that is to some extent endothelial dependent. And you can maximize that by giving acetylcholine. That is in angiographically normal vessels. But what happens in vessels that have extensive atherosclerosis? Exactly the opposite. So in fact, during exercise, these vessels will constrict, and even more, almost to 40% with acetylcholine. That is impaired endothelial function in the coronary arteries. And that's what generates ischemia, increased demand and reduced supply. Now, in the simplest form, and during exercise testing, we look at the ST segments of the electrocardiogram. And the ST segment deviation in the repolarization part of the ECG reflects the differential repolarization between the epicardium and the endocardium. And if it's depressed, this dashed line represents 1 millimeter. And why do we care about 1 millimeter? Because that was the graph paper on the original EKGs that were used to develop the exercise response. There's no magic to it. It's just 1 millivolt. Abnormal is a flat ST segment, looking ST segment, and it's even worse if it's down sloping. There are, of course, things other than ischemia that can alter that repolarization. Left ventricular hypertrophy, accessory pathways, medications, a variety of different things. So it may be sensitive, but not terribly specific. Now, the other challenge is, when do you want to make this measurement? It's pretty easy if it's flat, but what if it's a normal response where you get a depression of the J point and then a upsloping during recovery? Typically, we would wait 80 milliseconds, where the peak ST depression is at 2 millivolts, and 80 milliseconds after the J point is the measurement point. You can see that the ST segment is changing and heading towards the baseline. But this then would be normal, and this would be abnormal. So 2 millivolts, 80 milliseconds afterwards. Now the problem comes when you get a flat ST segment depression and then very rapid return to normal. You then have to shorten that duration from 80 to 60 milliseconds to pick that maximal ST depression. Now, if people have abnormal ST segments to begin with, you need to use adjunctive imaging. So for example, echo is quite common, and here's the apex of the heart that normally is beating. Notice that it's twisting in a counterclockwise fashion at rest. And during exercise, when the heart is beating faster, it's increasing even more. And we look at the different walls to see if there's wall motion abnormalities. You also can inject nuclear tracer, which follows myocardial blood flow. And here's a short axis view that's similar to this one here at rest in two different parts of the heart and then during exercise. And you can see that there's less intensity here. This is what the nuclear cardiologists mean when they say reduced perfusion in a coronary vascular bed. So in clinical exercise testing, how do we standardize the exercise stimulus and the cardiovascular assessment? Well, there are lots of different ways to measure exercise capacity, some of which are better than others. And in order to understand how to apply exercise testing in the clinic, I want to remind you of one of the most important physical and physiologic concepts in all of science, and that's called the Nyquist limit. So everybody think about what happens when you look at an airplane propeller, right? An airplane propeller starts turning, and when it starts to turn slowly, you can see it looks like it's going in this clockwise direction. So our eye will only sample at about 35 frames a second. So the first sample is here, the second is here, the third is here, and you can see it's starting to accelerate. But if it goes faster than this, the next one might be here, and the next one might be here. And the optical illusion then is that it's going backwards, right? So you need to know, if you want to measure functional anything, your Nyquist limit is half of the maximal rate at which you can detect something. So if I had a ruler with divisions that are this big, I can't measure anything that's smaller than half of that measurement length. So that's called the Nyquist limit. We use it in ultrasound all the time, and it's true in everything, including exercise testing. So most of what you guys see in the clinic is something called the Bruce protocol, which goes for 3 minutes per stage, starts at 1.7, 10 miles an hour, and then amazingly increases in both speed and grade with huge jumps, 3 METs at each workload. Why did Robert Bruce do that? I mean, this is a ridiculous protocol. Makes no sense at all. It turns out that Robert Bruce had a horse treadmill in his garage, and that's what he used to develop. He only had fixed gear ratios, so that's what he had to use. So, but it doesn't make any clinical sense. And in fact, if I look at a histogram of exercise duration at Parkland Hospital, the vast majority of patients stop at 3 minutes and 30 seconds. That's because when you transition from the first stage to the second stage, all of a sudden this goes from 4 to 7 METs, which is super maximal for most patients. And so everybody just falls off there. And if I told you that 1 MET was important, you got to use protocols that have no more than 1 MET increments. And so the one that I like for hospitalized patients is called the Naughton protocol, which has a fixed speed and goes up by 3.5% grade every 2 minutes. For fitter people, you can use a Balke, which is 3 miles an hour, or a modified Balke at 4 miles an hour, but each one increases only by 1 MET every 2 minutes. So if I can summarize quickly, I want to leave you with a couple of quick ideas. And the first is exercise testing can determine functional capacity. That's what it's best at. It can evaluate the hemodynamic and cardiovascular function during physical activity. It provides a predictable and objective setting for the evaluation of symptoms, chest pain, dyspnea, fatigue, of uncertain etiology. It can detect the presence of myocardial ischemia during increasing myocardial oxygen demand that is sufficient to cause a shift in the ST segment of the electrocardiogram. And it can identify a threshold of systemic and myocardial work rates beyond which ischemia is likely to be present. Finally, it provides important clinical information that may assist in the estimation of prognosis, particularly by identifying low-risk groups of patients who have ischemic heart disease. Now, there are also some things that exercise testing cannot do. It cannot determine the structure and composition of an atherosclerotic plaque. It can't tell you whether that plaque is lipid-laden and rupture-prone versus hard and calcific or rupture-resistant. It cannot identify the presence of atherosclerotic plaques then that will rupture and cause a myocardial infarction. It can predict the response, or it cannot predict the presence or absence of ischemia at work rates greater than that achieved on the test. Now, when I present all this physiology to a group of trainees, often there are a few people in the audience, and because this is virtual, I can't see you all, but I know some of you are saying, Dr. Levine, please cut the crap. All I want to know is the test positive or negative? That's why I sent the patient to you in the exercise lab. But to have a test that's positive or negative, you need a test that's either a disease that is present or absent, and a test that's positive or negative. And there just aren't that many conditions in medicine that are either present or absent, and there are few tests that are absolutely positive or negative. Indeed, life is a matter of grayness. And if I give you this box diagram, which talks about exercise results in coronary disease, and I put all these in quotes because to develop the sense of sensitivity and specificity, I need a test that's positive or negative and a disease that's present or absent. Then if the test is positive and the disease is present, that's called a true positive, right? And if the test is positive and the disease is absent, that's called a false positive. And for those of you who read about exercise testing, you can look at here, this is a meta-analysis of 150 studies looking at the sensitivity of exercise testing. And that may range from 20% to more than 90%, with a mean of 68%, depending on the circumstances of the study. Specificity is a little better, pushed more to the right, with a mean specificity of 77%. Well, where does this concept originate? And to address that, most of you have heard this term in your training about Bayes' theorem, right? Which gives you the posterior probability of disease based on the pretest probability of disease, and develops the L, or likelihood ratio. And the whole concept of Bayes' theorem was first popularized by Rifkin and Hood in the New England Journal in the late 70s, talking about exercise testing. And here's some of the data from that original study, which gives a likelihood ratio of 7.4. And it is because of this curve, that you are often taught that exercise testing is really most valuable in the intermittent pretest probability, not very useful if it's low and not very helpful if it's high. Well, it turns out that's not what this study showed. This curve was derived from 1 millimeter of ST depression. Remember, I told you that just comes from the graph paper. And in fact, if you look at the paper carefully, this gradient is dramatically different depending on if it's 1.5 to 2, 2 to 2.5, or the ST segments are downsloping. Now, your likelihood ratio is 64. And even if you have a low test probability, the chances of having important coronary disease are very small. So if you go ahead and read the paper, which is this Bayesian analysis of ECG stress testing, this is the conclusion. The use of the terms positive and negative are inappropriate to describe most stress test results. Instead, the results should be interpreted in terms of a continuum of risk based on the extent of SC segment depression, and I would submit to you the nature of the exercise functional capacity and exercise response. And the reason for that is that angiography is not a very good test. All these analyses that I just showed you set a cross-sectional narrowing of an epicardial coronary artery of either 50 or 70%. But that kind of stinks. There's actually terrible intra and intra-observer variability, particularly with lesions that are in that 30 to 60% range. Lesions can be eccentric, disease can be diffused, and cath is just a static resting measure. So, and here's why it's a problem. right? Here's the angiographic view. If this upstream is 100% of a normal coronary artery, and here's a lesion that would be 50% of this, or 25%, so 75 or 50% lesion. And if we just give you a cross section across those, but what if there's diffuse disease? Now, this would have been 50%, looks like it's normal. And the cath guy would call this a 50% lesion. But in fact, it's a 95% cross-sectional diameter lesion. So cath just isn't that good. And if you want to read a very nice, very recent review of the pathobiology of coronary disease, it was published by Peter Stone and Peter Libby in JAMA Cardiology just a couple of months ago. I don't have time to go into all that, but it really describes this whole concept of progressive development of coronary artery disease. And it turns out that coronary flow reserve, the amount that the heart can dilate and increase that myocardial oxygen blood flow, is not correlated very well with percent stenosis. So a guy named Mel Marcus at Iowa did a lot of the pioneering studies in the late 80s and early 90s. And the normal ability of the heart is to increase its flow by at least 3.5%, generally about 5 times, 3.5-fold to 5 times. And here's the relationship between percent stenosis and coronary flow reserve. There's no relationship at all. This is completely useless if what you're asking is, can the heart increase its flow to meet metabolic demand? Now, one of the percent stenosis is also a very poor measurement of ST segment deviation during exercise. And this is a really nice study from the Marcus group I want to review with you in a little detail because it helped to inform my thinking. And they took a bunch of people who had single vessel coronary disease and had an exercise test and a cath. And they looked at those who had less than 1 millimeter and more than 1 millimeter of ST segment depression. And you can see the average percent stenosis was about the same, no major difference. On the other hand, if they asked what was the coronary flow reserve, and they used a 3.5 times increment, man, now it's a pretty good measure, right? So those who had ST segment depression had abnormal flow reserve, and those who didn't had normal flow reserve independent of the percent stenosis. And in fact, if you look at a gradient of coronary flow reserve, all of those who had very severe abnormal coronary flow reserve, so 100% of them had an abnormal exercise test. And those who had normal coronary flow reserve, very few of them had abnormal ST segments. So let's go back to our box diagram again, and let's ask about what happens under different circumstances. What about this false positive ECG? So in other words, the test is read as positive, but there's no compelling obstruction on cath. It's possible that cath is underestimating the severity of the disease, particularly in diffuse disease where that minimal luminal diameter is important. It's also possible that there was coronary vasoconstriction during exercise, like I showed you in the cath lab. And in fact, rather than calling this a false positive ETT, I would call it a false negative cath. Of course, it's also possible that the ECG is caused by something else, and it's not reflecting of ischemia. What about that false negative ETT? So the test is called negative, but cath shows more than a 50% lesion. Maybe cath is overestimating the severity of the lesion, and that's very common with visual interpretation compared to quantitative coronary angiography. It also may be that cath is overestimating the functional importance of the lesion. In other words, it's not measuring coronary flow reserve. So rather than a false negative exercise test, I would call this a false positive cath. Of course, it's also possible that the ECG ischemia exists, but the ECG is insensitive enough to detect it. And it's also possible that the lesion's not functionally important at the level achieved during the exercise test, which reminds me to remind you, never stop an exercise test at a predetermined heart rate. That 85% of maximal predicted heart rate is just nonsense. And it mostly is designed to help move patients through the exercise lab, as opposed to giving you, the clinician, the information that you need. So let me give you a few take-home messages. For exercise physiology, I want to remind you that physicians providing care to active people need to understand the specific cardiorespiratory demands of different activities in order to interpret a cardiopulmonary exercise test. Data obtained from a CPET include VO2 max, exercise economy, velocity at VO2 max, maximal steady state from ventilatory or lactate thresholds, and ideally cardiac output and maybe even respiratory flow volume loops, which we didn't talk about. Cardiac output increases proportional to VO2 with an early increase in stroke volume and a later rise in heart rate, which is driven by metabolic signals in skeletal muscle and regulated by the autonomic nervous system. Ventilation is also driven by metabolic signals in skeletal muscle, and in some athletes in whom every step of the O2 cascade is optimized may actually limit performance at very high ventilations. Take-home message for exercise testing. I hope you'll walk away from this talk thinking that exercise testing is not positive or negative because coronary disease is not present or absent. But exercise testing is a powerful tool to determine functional capacity in clinically relevant fashion that directly reflects a patient's activity. It identifies the myocardial and systemic work rates that may provoke ischemia within the limits of the EKG to detect it, and it assists in the management of patients with cardiovascular disease. So with that, I think I'll stop. Anyone who's interested, I do have a bunch of cases that I can share with you. Sometimes I'm not sure if you all want to hear that, or if you want to ask questions. It's about 5 minutes or so of very simple cases. I'll leave that up to you, Ryan, and the residents if they'd like to hear cases or just ask for some questions.
Maybe I'll open up the floor to anyone who has a question to start with. And otherwise, I think the case would be great in the last few minutes that we have.
Dr. Bell?
Hi, Dr. Levine.
Hi, Kathy.
Sorry. I really enjoyed your lecture. And I have to tell you that I was doing some exercises while I was listening to it, just to let you know I was utilizing this virtual meeting. Do you have any comments to make about exercise testing in adaptive athletes or in older people that want to take up adaptive sports if, for instance, they've had a stroke or something later in life?
Yeah, obviously, every adaptive athlete, let's call them, is different because the nature of the limitation is very unique and individual. So to do testing under those circumstances requires creativity. For someone who has trouble with balance, you may need to do a sitting on a bike. If they have trouble holding their trunk up, a semi-recumbent bike with the back supported can be done. If they have trouble with one leg or both weakness in the legs, then an upper body ergometry can be useful, though recognizing that the ECG can be pretty noisy when you're using upper arm ergometry. So I do think that functional capacity is really important. It certainly is in all your patients. And being able to create a scenario that you can evaluate the patient objectively in a way that challenges them and they can accomplish gives you a very good idea of what their functional limitations might be that might be beyond just the mechanics of motion. What do you think?
Well, thank you. I certainly have been involved over the years in trying to get exercise testing for some patients is often challenging because you need to have a exercise testing partner who's interested in being creative and helping to do that. But I think as we look at trying, the exercise is medicine mantra that we're trying to now deliver to our patients with, say, neurological impairments. I think we're going to have a way to address this as they're older, or have things like strokes or spinal cord injuries and things that are going to really affect their ability to manage cardiovascular responses.
I agree. And, there are other tools within cardiology to test people. You can give a regadenoson injection to vasodilate the blood vessels and create a coronary steal phenomenon. You can do a dobutamine infusion, which increases myocardial work, either with echo or nuclear imaging. And all of those are fine if the patient literally cannot walk or can't do any activity, to look and see if there's provocable ischemia. But it lacks all the functional information that are a critical part of the exercise testing. So my mantra to my fellows and students is, the first option is to do an exercise test in people who can walk. Just because it's convenient and the patient doesn't get sweaty and it's easier for the technicians to do, doesn't mean you should do a nuclear test or a dobutamine echo. Though sometimes you do have to do that.
Thank you.
Let me see, we have a question here in the chat box, Dr. Levine. If you're in a setting where exercise testing is limited, what is a poor man's way, quote unquote, of estimating METs? He said he remembered hearing anesthesiologists using climbing 2 flights of stairs as greater than 4 MET equivalent, becoming out of breath. Are there more examples of activities that can be used similar to Naughton protocol to approximate METs in a stepwise fashion based on a patient's reported exercise tolerance?
So 2 flights of stairs is hard to do. That's closer to 7 METs than it is 4 METs. And of course, it depends on how fast you climb the steps. I think most people don't realize that lifting your whole body uphill fast is really hard. And some people will say, well, oh my gosh, I can't climb, I'm short of breath at the top of the stairs. Well, 2 flights of stairs is probably closer to 10 METs. And so it's near maximal for a lot of people. And it's not surprising that people are short of breath under those circumstances. So I think, of course, there are activities, and remember the Naughton protocol is just 2 miles an hour at different grades. You could also just walk at different speeds. 2 miles an hour is 2 METs. 3 miles an hour is 3 METs. 4 miles an hour is 4 METs. And you can just have someone walk in the hallway. There are shuttle tests where you time how fast people can walk in between markers. I don't like the 6-minute walk test because it's so subjective, and it's particularly for fitter people, it's kind of silly. For very unfit people, it's not bad as a measure of functional capacity, but people have to get used to it to use. In fitter people, and that's probably not what you're talking about, but you can go ahead and do a 2-mile run time, and that'll tell you what your VO2 max is, almost as good as a CPAT. And you can look on the compendium of physical activity that I shared with you, that will help you get some idea of what METs are required to do what activities. Kathy's asking on wearables. So I guess what I would say is this: I would throw in the garbage any bullshit that comes out of a wearable about your VO2 max. Did I say that strongly enough? So those come from algorithms that have such error that they're essentially useless. Now, what it does is say, if you are a certain age, you should have a certain heart rate during exercise. If the wearable uses the GPS or the accelerometer to measure speed, and you can actually do something like a 2-mile run time, then it's not bad, because those relationships are really there. But the problem is that these wearables are so noisy, and frankly, if a lot of them use a photoplethysmogram, to measure heart rate, and as soon as that watch starts to move on the wrist, it's useless. It's not measuring anything. So I don't trust them very much.
Great. Thank you, Dr. Levine. It looks like we're a few minutes over 11. We're out of time. That was a terrific presentation. Really appreciate you sharing that with us.
Great.
And we'll be sure that we share your link there to that summary in the beginning with everyone. And again, appreciate you spending your morning with us.
Sure. Nice to
Okay.
meet you all. Anyone who wants to come up and tour the unit, give me a buzz, reach out to Dr. Guillot. We'd love to have you come visit and see what we do.
Excellent. Thank you so much.
All right, take
Have a
care.
great day.